advising TT, but now there's been a shift to TD, especially in the government sector. I believe in the private hospitals, we are still with TTs, but in the government sector, they have TD now. 2 doses are taken. During pregnancy, there are some organizations that have recommended the flu vaccine as well as Tdap especially towards the later trimester, that is between 27 to 36 weeks. Again, it is at the recommendation level.
Each and every pregnancy. In every pregnancy, you can repeat this.
Every pregnancy. Yes.
Okay. Thank you.
Pregnancy. However, it still remains a recommendation. It will take some time, I guess, before it becomes a guideline and a regular practice. The use of MMR and varicella before they get pregnant, the recommendation again is 4 weeks before pregnancy, but practically I believe most of us say take the MMR vaccine or the varicella vaccine at least 6 months before conception. This is only at a suggestion level. I'm not sure if it's a recommendation or even a practice, but at a suggestion level, yes, there are a lot of patients who do take it before they conceive. The screening for certain viral infections like HIV, HPSAG, VDRL, screening, identifying and treating, I believe has been very comfortably going on for several decades. The last two speakers have spoken about toxoplasma, so I think I'll just skip that point.
Okay, one more question, Dr. Sumita. So people are saying that there is a high incidence of strep pneumonia infections for the newborn. First 6 weeks they are not covered. Is there a role for giving conjugated pneumococcal vaccination 13 during pregnancy if the mother is not vaccinated in the past?
I'm not aware of any recommendation regarding the same for pneumococcal vaccine during pregnancy.
But there are reports of cases in which newborns are getting pneumococcal meningitis, whether this vaccine is one more question. So now COVID is going to come, COVID vaccination. What about this COVID vaccination during pregnancy? You know that you are giving influenza. COVID is a similar condition. So can you give protect your women against COVID? Recently, I have a influenza is a killer disease in pregnancy. Like that, I don't know whether COVID is a killer disease in pregnancy, but one of my patients' mother expired and baby survived. So we have to see whether COVID vaccine can.
So regarding the numbers, the COVID virus has been extremely kind to us, especially our pediatric and newborn group as compared to the older group. So extremely thankful to the virus for being kind to us. We are very skeptically, we are waiting for the vaccine to come out. Very fast forwarded trials in the vaccine. So hopefully the vaccine will come, but hopefully we don't have to use it too much because the babies have done well and they'll continue to do so.
Okay, so thank you so much, Sumita, for the message is quite clear. So you have to vaccinate our pregnant women against flu, Tdap, and also prior to delivery, it's very important that you have to see MMR and varicella well before that. And all this infection has to be, HBsAg is very important, and also VDRL. And as she said correctly, pregnant women should not handle vegetables or raw vegetables, or if at all they want to use, they have to use a gloves and all that. Okay, thank you so much. Okay, next question, please. Dr. Lins. So we are between devil and deep sea. So please comment about the milking of cod, the very important issue. The people say milking of the cod is good, they will get more iron. Some people say if you milk the cod, then they will get jaundice. So what's your opinion? To be or not to be, Dr. Lins?
Thank you, sir. Thank you for that question. Thanks to Kottayam and enough for giving me this opportunity. Actually, really, in this case, I feel, at least in my hospital, I am the devil. And the obstetricians feel I am really a devil, because when I really joined, the obstetricians actually, they used to cut the cord immediately. So when I told them of the delayed cord clamping, they were like, why to delay the cord clamping? It is not needed. The cord has to be immediately clamped and the baby has to be shifted to the mother side. So it took around 2 to 3 months for me to convince my obstetricians of the benefits of delayed cord clamping. Now, at least in my institution, obstetricians are doing delayed cord clamping, at least when I am there. I don't know if it is happening if I am not there. So basically, when coming to delayed cord clamping, it is actually, as it is being shown by the AAP, in our new NRP also, delayed cord clamping for around 30 to 60 seconds is really beneficial. It has a lot of advantages, like it decreases the incidence of IVH, necrotizing enterocolitis, decreased chance of anemia, decreased chance of hypotension, decreased chance of blood transfusions. The only side effect that is being reported is the increased incidence of neonatal jaundice. So coming to the topic proper, so to convince the obstetricians about delayed cord clamping is very tough for me. So coming to umbilical cord milking, it is even more tough. So when we compare umbilical cord milking versus delayed cord clamping, actually this is actually a recent RCT that is being published in JAMA in 2019. It is actually shown that there was no statistically significant difference in the rate of composite outcome of death or severe IVH. But there was actually a statistically significant higher rate of severe IVH in the cord milking group. So this study was terminated early because of the poor outcome before the conclusion. The next slide.
Okay, please project the slide. Please project the slide, Dr. Sumita. Unfortunately, my laptop is working, so I am out of control. Dr. Sumita.
Yes, sir. The slide is here, sir.
Yeah.
So this is actually another RCT that is published in ADCFN in 2018. This also compares cord milking versus cord clamping. So there was actually no advantage of umbilical cord milking, frankly, when compared to immediate cord clamping. So if someone asks me if cord milking is recommended or not, I would like to say still evidence have to come up to prove that cord milking is effective when compared to delayed cord clamping. So at present, I think delayed cord clamping is something which has to be followed universally, and cord milking, I think still evidences are more needed.
Thank you so much, Dr. Lins, for your comments. And so we have to practice delayed cord clamping. To Dr. Jayakumar, sir. So what is the best cord care practice in the absence of generalized bleeding tendency? It's a common thing that we come across oozing from the blood, and they used to run away. Oh, blood is coming. So that's a very serious thing. So is it what is some situation, Dr. Pierre? Dr. Jayakumar? Dr. Jayakumar, can you hear? Dr. Jayakumar? Hello? Are you there? Dr. P.R. Jayakumar?
Yes.
Please come in.
Am I audible?
Yeah, you are audible.
Yeah. So it's a best the best practice is masterly inactivity, because we are nowadays clamping and cutting the cord with the most utmost aseptic precautions, and mild bleeding while at this stage of shedding of the cord is a normal phenomena. No active treatment is necessary for that, and the practice of applying antibiotic powder to the stump is not that good practice, and there is no need of any applicants to the stump. And mild oozing from the stump is normal, and mild bleeding is normal. But if it is severe enough, or there is evidence of infection in the form of increasing redness and edema with pus discharge, then you have to rule out early HDN and sepsis. The current practice of frequent hand washing with soap and water, followed by the use of sanitizers for prevention of COVID, is good for cord care also. And not social distancing and non-touch is the best method. Masterly inactivity.
Correct, sir. You are absolutely correct. This minor oozing is big due to the crust formations, and that cause injury. So what you can do is that you can cleanse the area, and this oozing will stop. But if there is massive bleeding, as he said correctly, you have to rule out SDN and other coagulopathies. Thank you so much, Dr. Jayakumar. Next question, please. Dr. Sarjan, is it necessary to check the blood sugar in asymptomatic baby? Dr. Manoj was telling in the today's his presidential address. So people are afraid of this hypoglycemia, and they start on formula. Up to what level you could wait in terms of this blood sugar level to start formula or parallel glucose for a newborn baby, otherwise normal. So people are afraid of hypoglycemia. They say that hypoglycemia produces devastating changes in the parietal and occipital region. Start formula, otherwise baby will develop hypoglycemia. So what's your opinion? What's the recommendation, Dr. Sarjan? Dr. Sarjan? Dr. Sarjan, can you hear? Can you hear me? Dr. Sarjan?
Hello, can you hear me?
Yeah.
Hello, first of all, who are at risk babies? That is what we should ensure, that only that if the baby is a preterm baby, if the baby is small for gestational age baby, or if the mother is a diabetic mother, those are the at-risk babies, or large for gestational age baby. But there are certain babies you may miss. Only that if the mother is having a altered GTT in the second trimester and they have not followed it up correctly, you may not get adequate history to confirm that the mother is diabetic. So we may miss such a mother because the mother is not proved to be diabetic, mother is not taking any medication, not having adequate antenatal care. So this baby may go in for hypoglycemia. We have had babies like that where the mother did not have adequate antenatal care of her hypoglycemic control, and the history was missed because of that. Second is that if the mother is taking maternal beta blocker therapy, these babies are also should be included in at-risk babies. One is that. Second is that, is there any chance of any baby developing hypoglycemia if the baby is fed on colostrum only, because of day one mother is having colostrum only, whether is there a chance of developing hypoglycemia if the baby is not at risk? There is a study conducted by Cochrane, it is given in the NICE guidelines. There they have confirmed that if the mother is having colostrum only on the day one, the baby is not going to get any hypoglycemia if the baby is not at risk. So we can have breast milk continuation or colostrum alone to maintain normoglycemia in a normal baby. But at-risk babies, we have to be careful. All at-risk babies, especially those babies where the maternal diabetic history is not evident, we may have to be careful. And there's a criteria there, both IAP or National Neonatology Forum and American Academy of Pediatrics has given adequate guidelines for the management of hypoglycemia and how to do monitoring of hypoglycemia in at-risk babies. Of course, we know that we should check the blood sugar after 1 hour. The American Academy of Pediatrics, Indian Academy of Pediatrics is saying that after giving first feed, you have to check. The American Academy of Pediatrics is saying that do blood sugar within first hour whether the baby is fed or not. So what the Indian Academy of or NNF is saying is that if the blood sugar is less than 25 milligram, definitely we have to start IV dextrose, even the baby is not symptomatic. But if the baby's blood sugar is more than 25, you can have a trial of feeding and check the blood sugar after 1 hour, half an hour to 1 hour, and see if the baby is not responding to feed, we may have to start IV therapy. But what American Academy of Pediatrics is saying that if the baby is 4 hours old, after 4 to 24 hours period, if the blood sugar is between 35 and 40, the normal blood sugar is 45. If the blood sugar level is between 35 and 40, you can continue with feeding and try. But the National Neonatology Forum is not saying that, but there is a slight disparity in the management of blood sugar in the first 24 hours. What I have to stress is that there is no need of any additional feed if the mother is not having any risk factor, because colostrum alone it is proved that colostrum alone can maintain normoglycemia in normal baby. Second is that we should not miss infant of diabetic mother because the antenatal history may not be adequate and the mother is on beta blocker therapy. Third is that if the blood sugar is more than 25, you can have a trial of feeding.
Thank you, Dr. Sarjan. The message is very clear. So it only in high risk pregnancy, in infant diabetic mothers and mothers on beta blockers, then only you have to consider this formula. Routinely, in genuine or all cases, no need of any formula. So they used to express and say that, oh, she doesn't have enough breast milk. So it's very important that mankind very advanced in the society. Breast milk won't come if we express. Only when the baby is sucked, then only the breast milk come. And also, you have to counter the allegation that the capacity of the newborn stomach is very small, around 4 ml per kg. They can't have 1 liter breast milk immediately after birth. So this breast milk is going to be wasted. So nature is provided in such a way that only a very small quantity of breast milk is available immediately after birth. And that's where, so you have to give that. There is no need of any formula for full-time newborn babies. So that can be a problem. They will never suck the breast, suppose if you offer a formula, because they know that there is easy way of getting energy source. So never offer formula to a newborn baby immediately after birth. So the point is well taken, Dr. Sarjan. Okay. Next question, please. Dr. Sumita. Could you please change the slide? Dr. Sumita? Dr. Sumita, are you there? Sorry, I can't. Yeah, next slide, please. Sumita, is any problem in changing the slide?
Yes, it got stuck for a minute.
Okay, thank you. So sorry. The question is to you. So baby colics kill sleeps of everybody. So this is happening in each and every house. Is there a last word in the management of newborn colic, and what's the total colic management?
Sir, thank you, sir.
You're not audible. You're not audible.
Yes. It's a very difficult question to answer, sir. How to manage colic in newborn? So I think my total colic management involves this one strategy of buying time, wherein I tell them that this is a phase that we might have to face. You will be facing it, and that it will pass in time. So you have to buy a few months. Different strategies have been tried, whether it is simethicone or fennel oil, dill oil, acupuncture. A lot of research has been done over the last several decades on how to calm these babies and to prevent them from crying excessively. However, none of it has much evidence, but I'm sure that all of us will at one point agree that we are aware of Colicate drops, we are aware of Colimix drops, and we know how to use it. So I'll not say that I've never seen it or that I've never used it, but definitely it has no evidence. Is there evidence for using probiotics or lactobacillus? Yes. The only thing that is currently showing some evidence is lactobacillus reuteri. So this is the only promising treatment out of some 2,000 articles that have been pulled up in the systematic reviews that have come out in the last 2 years. This one particular intervention is showing some promise. Again, it's not standard of care, but I don't know if it is justified in using it, but at least it is something that we can look out for. I'm not even sure if this is available as a sachet as such, because most of it is lactobacillus rhamnosus. Reuteri is available in certain capsules, not really as a sachet. It's not commonly used. So I think my total colic management would be to buy time, and hopefully the patient stays with you.
So our Dr. Molel used to say that the main reason for colic is because not getting hide milk. So what's the comment about that? Is hide milk is very important. The baby is not getting hide milk, so there is high chance for colic and trouble for the parents. Is it true? What's your opinion?
There are 6 to 7 reasons why we have postulated. We have postulated for infantile colic, and this is one of the sixth or seventh reason that has been postulated. So, like you have always taught us, our reason on probably we don't know the exact reason why colic happens, but yes, hind milk is important for sure, sir.
Okay, thank you so much. In my practice, what I usually do that, even though you are used to keep the baby over the shoulder, I used to keep the baby in upright posture by keeping over the handling the baby in the armpit. So with that, within no seconds, the baby used to expel the gas, and most of the babies are comfortable. Anyway, so if everybody this managing colic is really a difficult problem. So then is there whether increased intake of pulses by the mother will cause colic for the baby, or cow's milk whether it can cause colic for the babies? CMP is an important problem in the generation of colic. So what's your opinion, Dr. Sumita?
Cow's milk is one of the first things that are mentioned as a cause of colic. So whether it is a formula which is based on cow's milk, or if it is a breastfed infant, the maternal dietary intake has been accused. So there has been a lot of studies where they have tried to take out the maternal dietary, the dairy intake. However, maternal dairy, when that was taken out, it didn't really improve colic, that is a crying time in the studies. However, in certain studies, when they have taken out a lot of things, including the pulses, soy, in addition to dairy, there has been some difference in crying time. So there is some evidence to take out these things from the maternal diet, and it does decrease crying time.
So thank you so much. So this colic is going to be a big problem for each and every family. So let us sort it out in our own way. Okay, next slide, please. Next slide, please. Dr. Sumita. So Dr. Lins, so wet umbilicus after a fall of the cord is ugly. No doubt about that. So how will you manage a wet umbilicus? Are you concerned about the patent vitello-intestinal duct in all wet umbilicus? Dr. Lins, please.
Thank you, sir. Can we then give the next slide? This wet umbilicus is actually a really important issue, especially in the postnatal period. Many of the parents do ask or do come to the OPD, like there is some amount of white discharge, pus discharge, or some amount of clear fluid that is coming. So I think I missed that slides.
Okay, slide please, Doctor. Yeah, Dr.
Anyway.
Sumita, Dr. Sumita, slide please. So there is some problem.
Yeah.
And sharing. Yeah.
Yeah. Anyway, so when they come to here, so definitely during examination, we should definitely keep some of the important possibilities.
Okay.
Which it is like all the umbilical discharge or whatever it is not benign. So we'll have to properly examine whether it is a clear discharge or it is a pus discharge, or if there is something which is being protruding from the umbilicus, like if there is any umbilical polyp or any granuloma. And also important thing is we have to see for the type of discharge, especially if it is a clear discharge. Definitely there is a possibility of a urachal remnant, like if it is actually patent urachus, urachal sinus or things like that. And in case of a foul smelling discharge, or if it is a feculent discharge, definitely there is a possibility of a remnant, vitellointestinal duct remnant. So coming to this vitellointestinal duct, it is actually during the fetal life, there is actually a like it's like a connection between the gut as well as into the yolk sac. So mostly with advancement of gestation by around 6 to 7 weeks, this vitellointestinal duct mostly gets obliterated. Only in a few instances after birth, some of the remnants of this vitellointestinal duct remain patent. So it can present in a lot of ways. It can be present like clear discharge, or it can be present like a purulent discharge, or it can be in the form of an umbilical granuloma or a polyp, or even there are case reports of umbilical abscess, which later turned out to be this patent vitellointestinal duct. So in any case,
okay, Dr. James, what's the management of umbilical granuloma? How do you manage umbilical granuloma?
Most cases, actually, I think most of the umbilical polyp or granuloma, there are actually there are like things which are being told, like application of salt and things like that.
Common salt is sufficient. Common salt is sufficient. Yesterday, we used to do pottery and all that. Now people are comfortable with it.
Yeah, most cases.
Thank you so much. Thank you, Dr. Lins. Next question, please, Dr. Sumita. Dr. Sumita, okay. Dr. Jagumar sir, so better late than never. So my answer is no. And early the best. So my answer is yes. So people used to say that better late than never. Oh no, it's not like that. You have to manage, you have to diagnose very early. So that's the best policy. So what's the comment about male newborn urinary stream, UDT, and non-religious circumcision in male? Dr. Pia. Dr. Pia.
Thank you, Jagumar sir, for the very important question. So definitely
previous one, Dr. Sumita, previous. Yeah.
It's a very important question that we have to answer. That this is a very important intervention or important screening that we have. All of us should be very aware of. And poor urinary stream, mucus genitalia, hypospadias, phimosis, cryptorchidism, all are very, very important, and never neglect that. So it needs to be evaluated, and it is found that more than 2% of the general population is having a vesicourinary reflex and a lot other abnormalities, associated abnormalities. So we have to diagnose it early because of the availability of universal screening for almost all antenatal women. We are able to diagnose many of these conditions. But the classical screening method that Sir already mentioned, poor urinary screen, it is having high specificity, but it is less sensitive. A good urinary stream does not rule out genitourinary anomalies. But if it is present, and if it is associated with the severe phimosis, and if indicated, it has to be done as early as possible because the benefits are more with early circumcision. I fully agree with sir regarding that answer. And if there is hypospadias and ambiguous genitalia, and this all have to be evaluated using all as per the Society of Fetal Urology grading. Congenital hydronephrosis has to be followed up. Grade 1 and 2, of course, spontaneous resolution is most possible, and 3 and 4, surgical or antibiotic prophylaxis and follow-up is absolutely essential. And mixuritic cystourethrogram and DMSA, DTPS scan are being done in almost all cases in grade 1, 2 to 3, 2, 3, and 4. And hormonal assay and karyotyping is essential in ambiguous genitalia and hypospadias as well. In severe phimosis, already mentioned about the early circumcision, because it is by which we are able to prevent urinary tract infections, sexually transmitted diseases like HIV/AIDS and carcinoma penis also. So the ambiguous genitalia, micropenis, cryptorchidism, hypospadias are all contraindications for circumcision. And now universal screening for congenital adrenal hyperplasia is available, and you are able to diagnose it early.
So the point is very clear. In all male children, you have to see about the urinary stream. If they cannot say, what you can do is that you can take a video. When they come for follow-up, let them take a video and come with that video. And then from that, you will get an idea whether the stream is good or not. And also, my question is that if they don't want circumcision, could you please apply this 1% hydrocortisone at the tip of the penis till you are able to see the glands? So if they don't want circumcision, they are not religious people. So then is there a role for applying 1% hydrocortisone cream to the tip of the penis till you are able to see the glands? What's the comment about that?
Well, as already mentioned, we have to rule out any internal associated anomalies in all cases of phimosis. And after ruling out, if you try and the retraction fully is possible and on follow-up it is satisfactory, some of them avoid doing circumcision. But individual variations are there. Some going for, even in mild cases, for surgery. Some others not doing it and follow up with conservative measures. So it is up to the pediatrics surgeon who is to decide about that.
Pediatric surgeon always wants circumcision, and pediatric surgeon, they want always circumcision. But we pediatricians will try to avoid circumcision if it's not religious. Okay, so you can try that also, 1% hydrocortisone if they don't want circumcision. Okay, yeah, what's opinion of our neonatologist and Dr. Lins, Dr. Sumita, and Dr. Sajan about this application of 1% hydrocortisone to the tip of the penis till they are able to see the glands? I invite the opinion of the our neonatologist. Do you have any evidence against that?
I have to say that only thing is that the 1% hydrocortisone, the chance of balanopostitis, especially the fungal infection of the tip of the penis, there is a chance.
Suppose we are using acute use, whether that causes balanopostitis.
I don't know the exact because I have never used 1% hydrocortisone. I don't know whether it is really causing balanopostitis or not. But because we know the theoretic point of view is that steroid, any steroid applied anywhere in baby's nappy area, there's a chance of fungal infection. So we have to be careful about fungal infection, especially balanopostitis.
So sometimes it may be troublesome because if the phimosis is always risk for urinary tract infection, always there, no doubt about that. But it's very tight phimosis and they don't want circumcision. It may be worth trying, and that's my point. So Dr. Lins, what do you say? Dr. Lins is not
please
there.
Unmute. Lins, please unmute.
Am I audible?
Yeah,
now audible.
Sir, actually there is currently no exact guidelines whether to apply 1% hydrocortisone. There is no clear evidence whether to apply. As Sajan sir told, there is definitely risk for balanopostitis when you use for a chronic duration. So I think it is better to avoid 1% hydrocortisone.
You prefer circumcision?
It's actually, sir, it is I think we'll have to leave the question to the pediatric surgeons. That will be better.
Okay. Dr. Sumita, what's your opinion?
That I want to completely side with Dr. Lins and Dr. Sajan and say we should just leave it to the pediatric surgeon.
So the neonatologists favor, they are not against using this 1% hydrocortisone tip of the penis because they want the circumcision. Okay, because they are talking based upon evidence. Okay, next question, please. Next question, please. Dr. Sajan, we know SMS is short message service, but in COVID time, it is not short message service, it is soap, mask, and safe distancing. So what do you say this SMS in newborn practice during COVID time, or you want to use soap? So what's your comment regarding soap, bath, oil, and powder and creams for newborn babies?
First of all, there is not practical to apply mask or soap for the baby. So what we have to confirm is that the mother is having using mask, mother is having proper hand hygiene like hand sanitizer usage, and other related. Mothers can be always with the baby, but other attenders be at least keep a social distancing. That's what I talk about. I can say about COVID prevention, because no mask can be applied for the baby. Second question about bathing and other creams. Of course, bath can be given after around 4 to 6 hours after birth. Baby whose birth weight is normal, so there is no harm in giving a bath after 4 to 6 hours. Then water is the temperature of the water should be around 37 degrees centigrade, so that which must be a lukewarm water. Then what about the soap? Soap should be ideally a neutral or mildly acidic pH soap, because usually routine soaps is in alkaline pH. You know that in newborn baby skin there is an hydrophilic form and an acid mantle in the stratum corneum of the newborn baby. So there is a chance of disrupting that hydrophilic form and acid mantle if you are using normal soap. So ideally it's better always to use the synthetic detergent called Syndet, which is having a neutral pH or mildly acidic pH. That is the best one to be applied. And powder in the folds, yes, it can be tried to dry the folds, especially the armpits and the axilla area. But the problem is that powder may block the sebaceous glands, so there's a chance of the sebaceous ducts can get blocked. So we should be careful in applying powder, especially in the armpits and the axilla, of course. And powder should not be applied in the face and the chest area, because there's a chance of inhalation of powder. That's not good for the baby. And the scalp can be cleaned with shampoo. The baby shampoo can be applied for scalp, especially for removing the crust. But only thing is that this should not be irritant for the baby's eyes. And second is that it should not have adequate, more fragrance or smell. So those things and the color can damage baby's skin. So ideally, I don't know what shampoo is fulfilling all those criteria, but ideally shampoo can be applied for scalp. And oil application, emollient, especially moisturizing oil application, can be given. Only thing is that probably, especially in the hot climate, when you're applying oil, there's a chance of again obstructing the sebaceous duct, so chance of getting folliculitis. So we have to be careful when we are applying oil. And the cleansers can be used in the nappy area to clear the fecal matter. And the nappy area usually should be, the best thing is that what type of nappy should be used. So that we usually suggest cloth, and some people are saying that even commercial nappy pads are better than cloth, but we usually still, the old generation pediatrics still is in favor of applying cloth for nappy area. Only thing is that we should tell the mother to remove and frequent change of nappy and keep it open for some time in between nappy, so that the area gets dried up. And if the baby is having any nappy rash, we can apply some cream which contains zinc oxide. Otherwise, no cream or no ointment is needed for a baby.
So the message is quite clear. All areas of the baby has to be dry. If there is wet, there is chance for fungal infection. So, so we have to dry all the areas, maybe powder or using a soap with a Syndet bar like that. And you can give bath for the babies. And also, so this is the essential thing that Dr. Sargent has told to us. So the baby has to be completely dry rather than wet. Okay, next question, please. Dr. Sumita, what's the comment about sunlight exposure to manage newborn? Even yesterday I heard a direction from a pediatrician that you have to expose the baby to sunlight to prevent jaundice. Is it necessary to do? That is one question. Second question: is it necessary to do Coombs test in all cases of OA and OB incompatibility if you are planning early discharge? And also, do you routinely tell mothers? So that's a question not connected with this, because when they go outside, our country, we are missing a lot of cases of biliary atresia. So with that in mind, so do you advise them to send the pictures of stool to the healthcare workers, maybe to doctors or to some other people? So from that, we can identify this pale stools. So what's the comment to all these questions?
Studying sunlight, I think this has been discussed over the last so many years, and I think it's quite clear.
But still people are advising, expose to sunlight. Even pediatricians are advising to expose the baby to sunlight. Do you agree with that?
Yes, sir. I think all pediatricians and all academic forums will unanimously agree that sunlight doesn't help. But somehow this message hasn't trickled down to the elderly people in our society. However, we continue to discuss that it is not useful in all our guidelines and all our meetings. I think all of us will unanimously agree that sunlight does not really treat or prevent jaundice. But I think the real question here is how do we convince the elderly grandmother or the amachi that the sunlight doesn't help. So that is probably going to be our challenge. Regarding early discharge, so early discharge is when you discharge before 48 hours, somewhere around 24 to 48 hours. It is only advised for non-primary mothers. Now, why do we discharge so early? Probably there is some special situation that has prompted an early discharge, maybe a high turnover government sector unit or a special situation where the parents wanted to go early. So if you're sending the baby early, you must call the baby early. So the baby must come back in another 24, 48 hours for you to reassess the whole situation, whether it is with respect to feeding or jaundice. In such cases, hopefully you've looked at the TCB at least before you send the baby out, or you've at least checked the baby clinically and made sure the baby is not jaundiced before being discharged. If you felt there was a need to do bilirubin, yes, you can do a DCT along with that before you send the baby out. But if you thought the baby was clinically non-icteric, there is no point in doing the DCT alone. So it is not mandatory to do DCT before you discharge a baby early. But if you think there is some jaundice and you're doing bilirubin, why not add DCT also along with it? It gives you added evidence, but as a standalone investigation, I'm not sure it gives any particular evidence. So it's probably an individualized decision to do DCT in OB incompatibility setting where there is no jaundice and you're sending out the baby early. Whether you do it or not, the most important thing is to call the baby back as early as possible, probably another 24, 48 hours. Regarding sending the picture of stool to healthcare workers, yes, sir is very concerned about biliary atresia, and as we very clearly know, the time is of vital importance. So no point in being really late, no point in picking it up at 6 months of age. The point is to pick it up early. However, whatever technique you use to pick it up early will really make a difference to the life of that child in terms of the Kasai or the liver transplant. Now, what method we want to use to identify conjugated hyperbilirubinemia, whether it is to ask mother the color of the stools or to send stool picture is up to you, I think. But important for us to be sensitized and aware that we need to pick up direct jaundice if present earlier than later.
Okay, so that's a method that can be tried to, if you want to decrease the incidence. Late diagnosis of biliary atresia can be done so I have told you initially that if you come out with the video or the urinary stream like that, they can also post the color of the stool to the healthcare workers. Okay, thank you so much. There is no role for sunlight in the management of neonatal jaundice. The message is quite clear. Next slide, please. Dr. Lins, system. So we have a baby, all systems are okay. CVS, CNS, GIT, respiratory system, musculoskeletal system, endocrine system. But baby is getting only 30 grams at the end of 20th day. So we expect nearly 300 grams. But this baby gained only 30 grams. So how will you address the situations? This is one that we usually face in day-to-day practice. Only 30 grams weight gain on day 20. Dr. Lins.
Sir, thank you, sir, for the question. So we have a baby who is on day 20 with a 30-gram increase only. So actually, I interpreted this question in a different way. Sorry for that. I thought actually on day 20, baby had a 30-gram increase compared to the previous day. So
okay, so no problem. Okay, carry on.
I can tell, sir. So in this case, so we will have to confirm first of all whether this weight is accurate or not. So in this case, we'll have to recheck the weight again, whether this weight is correct or not. So and whether the calibration of the weighing machine is correct or not. Second thing is we'll have to assess the amount and frequency of the feed. So what will be the amount of feed that the baby is getting, and about the frequency of the feed the baby is getting. And also we'll have to assess about the spillage. So if there is any spillage, if there is any extra spillage. And so also we'll have to see for the type of feed, whether the baby is fed formula or whether she is on breastfeeds. And also regarding the night feeds also, whether she's fed properly in the night. There are some cases where the mother as well as the baby sleep during the night, and the feeding won't be that proper during the night time. So we'll have to assess properly regarding the nighttime feeds also. And also regarding then we'll have to assess the sleep pattern, whether the baby is having a proper sleep or not, whether the baby is having good sleep in the daytime as well as during the night time. And also coming to the urine output also, if the baby is passing adequate amounts of urine, like around 6 to 8 times per day. So all these things we will have to see if the baby is having an inadequate weight gain. And coming to so after that, if all these things are still we are not able to find the cause for the this weight inadequate weight gain, then I think we'll have to see for the various pathological causes. So in that case, we'll have to see if the baby is having any sepsis or any UTI or any other pathological causes which can cause a decrease in the weight gain. Also, we will have to see for anemia and various other causes like osteopenia also.
So Dr. Lins, as you said correctly, because in this situation, systems are okay, but as you said correctly, you have to exclude urinary tract infection. As Dr. Model used to say that if the mother is feeding every other second or every other minute or every other half an hour, then baby won't get the high milk. So that's also very important. So frequent feeding is important. You know, the recommendation as third month 3 hourly only. First month demand feeding and second month semi-demand feeding. So that's also an issue. If the mother feed the baby every other half an hour, baby won't get a high milk, and this can cause polyuria and dehydration, and baby won't gain weight gain. That also has to be addressed. Thank you so much, Dr. Lins. Okay, next question, please. Okay, Dr. Jayakumar. So Ayush, now the culture is Ayush. And everywhere there is Ayush. Herbal tonics are a big business in Kerala. So what's your comment about this traditional postpartum herbal supplementation to the mother, ignoring calories and proteins and water? They say that no water. No, don't drink water too much, then that will cause abdominal distension. So they won't take water, and if water is not there, how can they produce breast milk? So how will you ensure that lactating mother is getting adequate calories? So say comments about this herbal tonics and all that.
Sir, it is a usual practice in Kerala that it is mandatory that all immediately after delivery, all of them go in for indigenous medicines in the form of Arishtam, Lekyam, Kashayam for Prasava Raksha. So it is a usual practice associated with the Sampatyam. So it may be having a certain definite effect on the neonate as well as for the lactating mother. And the lactating mother, it is the period that maximum diet should be there, especially for lactation and getting all dietary requirements to meet the dietary requirements. And there is a hindrance definitely due to this patyam. So the probable effects on neonate, as usually we see in practice, are abdominal distension, constipation, sometimes diarrhea, and CNS depression, and also lactation failure occurring as a result of decreased intake, especially for previously non-vegetarian diet mothers. So the alcohol in the Arishtam can cause some adverse effect on the rapidly growing brain and liver. That the probable effects on lactating mother, the dietary restriction may lead to serious effect, especially in anemic and malnourished mother belonging to low-income group. And other than malnutrition, there can be micronutrient deficiency as well, and may lead to decreased production of milk, especially in the early phase, and lead to lactation failure. So the proper dietary advice already done by Dr. Sarjan, so I'm not repeating. So this is the maximum amount of both carbohydrates, proteins, fats, minerals, antioxidants, and fibers. Everything is needed for lactating mother. So it should be, she may be devoid for a period at least for 3-4 months.
Dr. Jaykumar sir is very right. So that means all aristam contains alcohol. In fact, some of this aristam may contain 90% alcohol. You know that during liquor ban, people used to take aristam. They used to for instead of alcohol. So better not to give this aristam to these new mothers, and they'll be excreted through the breast milk, and the baby will be toxic. So risky. So dissuade people from taking aristam during this.
Sir, I am advising them. They have already bought it, so it can be given safely for the mother of the lactating mother as well as mother-in-law of the lactating mother. It may be better for them.
So you can give. Not mother. You the size of setting that you won't trouble the mother. Okay, good idea, Dr. P.R. Jaykumar sir. Okay, good. Next slide, please. Next slide. Dr. Sajan, so there are many reasons for postpartum psychosis. So how will you ensure that our mothers are getting adequate sleep? Is sleeplessness is an important reason for postpartum psychosis? I don't know. So what's your advice regarding bedding in? How will you allow this bedding in for babies?
One is that we have conducted a study of mothers, around 60 mothers a few years back, the mothers of babies who are admitted in NICU. And this study was conducted by a MSc nursing student, and she has confirmed that around 80% of the mothers of babies who are admitted in NICU are having some type of stress, whether it is physical stress and mental stress. Both are there in mothers of babies who are admitted in the NICU.
Oh, that's good. Mm-hmm.
And second, what they are saying is the one is that sleep deprivation, because the mother has to get up for feeding the baby. Between every 2 or 3 hourly feed should be given for the baby. One is that. Second is that she herself will be having an anxiety whether this baby will survive or not, whether the baby will be having adequate neurological development or not. So we have to address both of that, because in this era of litigation and all, we are keen to explain everything to the parents, because suppose you don't explain everything to the parents, you may get it back, because they say that you haven't explained everything. But at the same time, when we are explaining everything, every complication of especially for a preterm baby, there's a chance of maternal anxiety. Of course, the maternal and paternal anxiety, that is evident from the study from what we have done. Second is that psychological and financial stress, because of, especially if a baby is admitted in a private institution, naturally the chance financial stress is too much. And in this era of nuclear family, there is no social support, especially for mother and father. Because the baby is admitted, mother will be here, father will be at home, and maximum one grandmother will be. So psychological and financial support is lacking in babies who are admitted in NICU. So what we have to give is that you have to keep a balance between adequately explaining the scientific aspects of care of a preterm baby, at the same time taking care that these mothers will not get stressed. So that midway is to be used for counseling parents. Second is that how we can get the financial support. I don't know. I don't have any answer. Only thing is that psychological support for the mothers, especially using the nursing students and the staff in the postnatal ward to give adequate psychological support and to feel that we are with them to save the baby. And second thing is, most of the parents are concerned what is the survival chance of their baby, especially if the preterm baby. And suppose we explain the international standards of survival, suppose the Western standard or Vermont expert network standard, they will get worried. So what is your experience? What is your survival for the baby? What is your experience with in treating that baby? That if that is explained well, that will be better taken care of. Second is that sleeplessness in the night. The most common problem for the mother is because of the 2 or 3 hourly feed for the mother. We have found an idea, a suggestion for that. What we do is that if suppose the mother is giving 3 hourly feed, we ask the mother to give express milk 1 hour, then after 1 hour.
Yeah.
Good. So 2 feeds will be taken. So out of that, first feed will be given after 1 hour, and the second feed, which is given when the mother is coming, that can be cut for 3 hours. So totally mother will get a sleep of around 4 to 6 hours. In that way, we can adequately time the feeding of mothers, of the babies, because most of the preterm babies, we know that we have to give 2-hourly or 3-hourly feeds. And second is, of course, the most important is the KMC, carry mother care, do help in relieving maternal anxiety. So we have to be give more stress in advising kangaroo mother care for the babies when the baby is stable.
Thank you, Dr. Sajan. So he has come up with another important issue of stress of the mothers of babies admitted in the PICUs or NICUs. So that also has to be addressed in addition to the sleeplessness. So for sleeplessness as a solution, so that is express possible can be given. In that way they can avoid the sleeplessness. And also the role of KMC, so that will give a lot of satisfaction for the parents. Okay.
Video
Points are well taken.
slide video.
Next question, please. Hello. So my laptop, because now this COVID season, could you please narrate briefly the management of a COVID baby? Dr. Sumita. Dr. Sumita? The management of a COVID baby, please.
Sir, am I audible?
Yes.
Yes.
Okay. So for a baby who is born to a mother who is COVID positive, what we are doing right now, or what the recommendations, there's been slight change in the recommendations that have come out since the last NNF guidelines. So yes, as healthcare workers, we need to use PPE while we go to attend the delivery of a COVID positive mother. Regarding resuscitation, we need to use full PPE. Regarding resuscitation, not much changes there. So whatever is normal NRP, that is what we need to practice. There was initially some concern about delayed
video is not there. Video.
Visible.
Yes, sir. It's there.
Jagma, sir?
video
Sir, logged out ayo naru doubt sir ne participant list il pettanna കാണുന്നില്ല.
Logged out ആയി എന്ന് തോന്നുന്നു.
വീഡിയോ പോയെന്ന് പറയുന്ന കേട്ടു.
Shall I just call sir on his phone?
Yeah. So yeah, now it's okay. Now it's okay. Fantastic. So we can see you. We can hear you.
Audible, sir. Audible, sir.
Okay. Please carry on. Please carry on.
Yes, sir. So like I was saying, so when a mother who is COVID positive is delivering, you wear your full PPE kit and you go and attend the delivery, and you follow NRP as your regular NRP. There is nothing special that you need to do with regard to resuscitation. Initially, there was some concern about delayed cord clamping and skin-to-skin contact. However, now that is also being considered to be brought back into the recommendations, including in our NNF guidelines. They are inching towards practicing delayed cord clamping and skin-to-skin contact. Regarding breastfeeding, certain organizations have gone for separation, but most of them have gone for breastfeeding, practicing respiratory hygiene. So there is really no evidence for vertical transmission. However, horizontal transmission has been recorded. So what we're trying to do is we're trying to offer breastfeeding by practicing respiratory hygiene. That is, the mother needs to use a mask. She needs to use hand hygiene and can breastfeed the baby directly. The problem that practically happens is if this baby has distress or requires NICU care and we cannot room in with the mother. So if possible, rooming in with the mother is what is happening. If the baby has distress, then you cannot really take this baby to the common pool. So then isolation is the next thing to do. So identifying this isolation area is probably the challenge. So as soon as if you can identify an isolation area, yes, this baby needs to remain until the baby's newborn's condition, whether it is respiratory distress or hypoglycemia, which will be managed as always. That needs to be sorted and the baby goes back to the mother's side. The rare situation where the mother is really ill and the baby is doing well, you can consider discharging the baby with the attender. Regarding testing the baby, there is a lot of difference of opinion. So what we're doing is currently we are testing at 48 hours and at 5 to 10 days. And we have these clear guidelines coming in from the government and we have to follow that, and we have to report also our test results. So that's what we're doing. But again, there is a lot of concern that when the test is done at 24 to 48 hours, apparently there is a lot more positive than when it is done at birth. So again, the horizontal transmission is supposed to be that quick. It doesn't really take a lot of time for the baby to get positive because of horizontal transmission. So again, there is a lot of talk about doing this test as early as possible, that is soon after birth. But currently what we're doing is at 48 hours. Regarding treatment, babies are not too symptomatic. Around 3% positive babies in mothers who are positive as per records, but we have not got too many sick babies as such. So no drugs have been recommended. Babies are not being too sick. Hopefully it remains like that.
Any misc being reported in newborn babies? Any idea misc?
In the baby, that the child that we have is around in our hospital currently was around a 6-year-old boy, if I'm right. As far as I understand, it has not been reported in newborn.
Okay, that's great. So they are great that misc is not being reported in newborn babies. Next question, please. Thank you so much for the information, Dr. Sumi. Okay, next question. Next slide, please. So how will you, Dr. Lins, how will you organize newborn baby's room in terms of light, sound, temperature, music, aroma, and electronic gadgets? So aroma is also important. So
it's a very important topic, sir. Actually, in the most of the NICUs, especially in sick NICUs, people mostly focus on the critical care part, like ventilator, CPAP, IV fluids, TP, and those sort of things. So most people forget this developmental supportive care totally. So it's also very important, especially if it is a preterm or if it is the babies in the NICU, the use of sound and light is very important. So as per AP recommendation, the sound level should not exceed 45 decibels in the neonatal NICU. So frankly speaking, even in my NICU, at times I feel the sound levels are very high, especially during the time of over, when the staffs give over. They will be near the side of the baby, and they give over near the baby in a very loud voice, especially around 7:30 p.m. If I go to my NICU, that sound level will be at the peak. It won't be like 45 decibel. It will be something like around 80 to 90 decibels. So it is very important to maintain a low environmental sound level, especially low when we are conversing. Also, we'll have to keep a low sound level. And we'll have to keep the mobile phone, pager, or whatever in the vibrating mode. Especially if we are taking rounds or whatever type in the neonatal ICU. The same is applicable to babies who are in the postnatal ward also. In that case also, the sound level has to be into the minimal level. And there are some NICUs where there runs a light baseline music. There are some of the NICUs, especially in the foreign countries, like especially Norway, etc. They have a light baseline music which is being running in the NICU. It has proven to be important in improving the neurodevelopmental outcome, especially in preterm babies. Regarding light, light is also very important. It should not be a bright light, and the recommendation is like it should be around 10 to 600 lux, the intensity of the light. So there is a practice which is called cycle lighting in preterm neonates. Some period of around 2 to 3 hours of switch on and switch off type of cycle lighting. It is also proven to be beneficial in preterm neonates to improve the neurodevelopmental outcome. So with regard to summarize, like in addition to the critical care management, we will have to give proper importance to the developmental supportive care, especially light and sound. It is very important.
What about the aroma? Is it a lavender smell is good or not for these babies? Because older people, lavender is good for sleep. So let us also try this lavender smell for the nurseries. Okay, thank you so much, Dr. Lins, for the excellent comments. Okay, next question, Dr. Smita. Sumita, please change the slide. Dr. Jayakumar, sir. So what about the best management of diaper rash? Because that's a common problem. So I said initially it should be dry, but beyond that, is there any suggestions from your side? Dr. Jayakumar, sir? Jayakumar, sir, can you hear? Okay. Dr. Jayakumar, sir, are you there? Dr. Jayakumar, sir? Jayakumar, sir?
Am I audible?
Yeah.
It's a very common problem that we faces, and the common causes for this is irritation due to urine and stool, and increased frequency of stools occurring, and infrequent change of diapers, and the pH change, and also the friction associated with the frequent removal of frequent stools, and maybe due to a contributory factor as colonization of fungus or bacteria, and increased use of soap. And the management depend on the causative factors and the avoidance of that. And initially, the proper attachment will reduce the frequency of stool, because it may be usually, especially in primary, maybe due to fore milk syndrome and the frequent feeding and frequent stooling as a result of fore milk, as already mentioned by many times by Mulay sir. And proper attachment will reduce the frequency. And sometimes the short-term course of probiotic will also reduce the frequency, and thereby reduces the irritation, and avoiding the friction by the rubbing and all, and the frequent change of, if you using a pure cotton cloth, it may be better, or diapers made of super absorbent polymers, and avoid soap and application of oil. And the first line of management is the use of emollients with as already mentioned by Dr. Sajan, with a neutral pH and slightly acidic, containing zinc oxide, petroleum jelly, and cod liver oil. And in severe cases, we can go in for low potency corticosteroids, 0.5% to 1% strength cream, and application for a short period. And if the rashes are exceeding the limit of contact, then you have to suspect fungal infections. In that case, you can topical antifungal agents can be used, nystatin, clotrimazole, or ketoconazole. And rarely we have to go in for antibacterial treatment using topical mupirocin. So I think with all these measures, we may be able to manage it well. Thanks.
All the points are well taken, Dr. P.R. sir, but the area has to be dry. If there is wet, chance for fungal infections. Dr. Sumita, next question, please. So, what's the vitamin D prescription for the baby, and how long? You have told that the vitamin D is very important for the mother. Now, my question is to you: how long will you give vitamin D? Some people say that there's no need of vitamin D, but worldwide they say that vitamin D is important. So how long will you give vitamin D, and how much you will advise, Dr. Sarjan?
So all guidelines say that vitamin D should be given 400 international units per day for 1 year, even in term babies. Having said that, I am an anti-vitamin D man.
You are
vitamin D man, can say that. So why I am saying is that, see, there is a position statement position statement by WHO in 2019 February. You can get it from the e-library of WHO, because this is a nutritional additive. What they have suggested is there is no specific recommendation. Further research is needed before advising it, but no guideline is mentioning this. What is the position state of WHO guideline? And second thing is that even last week, we have seen 2 babies who were on 400 international units of vitamin D, who were having a calcium more than 11 milligram. One baby was having a calcium of 12 milligram. The other baby was having a calcium of 11.5 milligram. So what is that? So what I'm saying is that if you are...
Dr. Sarjan, are you giving addition to these babies?
Pardon, sir?
Are you giving calcium in addition to vitamin D to this baby?
No.
They are getting only vitamin D.
These 2 babies were getting only vitamin D. And we have seen, even I have around 10 to 12 babies who were given vitamin D having a calcium of more than 11 milligram. but I don't, because there are so many arguments against vitamin D, but I don't, there is a paucity of time. I don't explain. What I'm saying is that ultraviolet index of equator area, nobody is mentioning, because everybody is mentioning about the brown skin, black skin, but nobody is mentioning of the ultraviolet index of our area, especially Kerala, and whether you are comparing ultraviolet index of New York or Delhi and Kerala when we are suggesting it. Second is that, is there any protocol to have regular monitoring of hypercalcemia in vitamin D supplement? We don't have. There is no proper study in Kerala about incidence of rickets in vitamin D supplemented or non-vitamin D supplemented babies. There is no proper study, but I have to say that as a recommendation, I have to go by the document saying that vitamin D should be supplemented 400 international units per day for 1 year. But if it is a personal opinion, I will go with the WHO saying that there is no specific recommendation. Further research is needed.
This is area for research, but till now, till new guidelines come, we have to follow what they say, that people are recommending vitamin D for international unit for 1 year or till you are giving breast milk. So it is very important, because even now we are getting so many cases of vitamin D in all the children. I have not checked the vitamin D status of newborn babies, but definitely this is the area of research. Thank you, Dr. Sarjan. Next question, please. So CMP, I have asked this question early. CMP is a cause for colic, and how will you manage the situation? So is there measures to detect the CMPI level or any other test evidence for the CMPI in the baby? Do you use extensively hydrolyzed formula, or use cow's milk or formula milk or breast milk? What is your suggestion? Okay, Dr. Smita.
Regarding cow's milk causing colic, it is a quite a gray zone. But what they have done is, there is some interference. But what they've done is, can I just mute one of the participants?
All child.
Yes, sir. I think we're back. So regarding cow's milk, whether it causes colic, there is a definite hypothesis. It is a gray zone. What we do know is that when you give cow's milk, if the baby has a lot of infantile colic and other symptoms, there has been the withdrawal and the oral challenge test, where you withdraw the supposed antigen and then you challenge and see if the symptom comes back. So that is what is classically described, that is the withdrawal and the challenge. Now, that said, it is not very common that there is a lot of infantile colic associated with cow's milk, probably because the colic happens in the early part of infancy, where a lot of them are on breastfeed. But if you have a baby who has significant colic, like we mentioned earlier, maybe restricting dairy and other things in the mother's diet might be helpful. And if the baby is formula fed for some medical reason and you think there's a lot of colic and other symptoms, say there is weight loss, there is blood in stools, the baby is not doing well, and you're convinced it is cow's milk protein that is doing the harm, you can go for hypoallergenic formula. But I'm not sure that colic is the one thing that will tempt you to go to a hypoallergenic formula. Probably something more severe, whether it is a proctocolitis, symptoms of proctocolitis, or severe weight loss, chronic diarrhea, all those things might tempt you to go into hypoallergenic formula. Regarding tests, some of the eosinophilic components have been tested, and I believe Jagma sir is doing a study on it. So regarding how to prove it investigation wise, shall I just throw the question back to you, sir?
One of my PG is doing a research thesis study in which he is estimating the eosinophilic cationic protein in the blood of patients with the cow's milk protein, and he says that preliminary research says that it is high in those patients with the cow's milk protein. And also those babies who are crying continuously, they have a high level of eosinophilic cationic protein. So the study is still not over. We are waiting for the research. Till that time, I cannot say anything. Thank you so much, Dr. Sumita. So yeah, so those cases you are suspecting, those patients are not responding, you have to use hypoallergenic formula. I don't know whether it's correct or not for older babies. Proceed. Next one, please. Next slide, please. Dr. Lins, so how you come across with a situation known as delayed fall of TSH. T4 is the upper limit of normal. Other it is delayed rise of TSH. Those things are there. So T4 is normal, but TSH is quite high. Like that, TSH is not rising. Okay, could you please, how will you address this situation?
Thank you, sir, for the question. Normally, in the neonatal period, we do thyroid screening, TSH screening, around 72 hours of life, and most centers we do TSH only. In some of the Western centers, they do both TSH as well as FT4. But in Indian centers, most of the centers they do only TSH. So there can be many cases which can be missed, especially case of secondary hypothyroidism, like central hypothyroidism, or any protein binding deficiencies. So we have two scenarios where when there is a delayed rise in TSH, especially if for a baby who is a very sick or a sick euthyroid syndrome, especially in ELBW and VLBW babies, this phenomenon of delayed rise in TSH can happen, especially also in sick babies, especially those babies with sepsis, congenital heart disease, critical congenital heart disease, etc. Also, they may also have delayed rise in TSH. So immediate newborn screening on day 3 might miss such cases. Also, similarly, in some of the monozygotic twins, especially if one of the twin is discordant for congenital hypothyroidism. So in that baby, the baby with congenital hypothyroidism may get some of the normal baby's blood, which contains the normal thyroid hormone levels. So in such cases also, there can be a delayed rise in TSH. So most of these cases will be missed in the initial newborn screening. So in all of these cases, they are repeat testing around 2 to 6 weeks is very essential to pick this delayed rise in TSH. Coming to the delayed fall in TSH, it can occur in mothers with Graves' disease, especially in fetal and neonatal hypothyroidism in Graves' disease, especially in mothers who are taking propyl thyroid, antithyroid drugs like propylthyroxine or methimazole. These babies will have the initial hypothyroidism due to this TSH receptor blocking antibodies and due to this antithyroid drugs. Thereafter, thereafter there will be a delayed fall in TSH when these things get settled. So in this case, only hello. So in all these cases, there is no specific treatment is needed. So this is actually this can't be considered as a fallacy. So ideally, we'll have to see for both TSH as well as FT4 during in the ideal scenario, we'll have to see both. Especially to pick these type of cases as well as to pick cases with central hypothyroidism as well as thyroid binding globulin deficiency.
So the message is quite clear. You can't take decision based upon TSH alone. If the T4, FT4 is above the normal range, but still TSH is high, it is because of delayed fall of TSH. One need not jump to conclusion that thyroid is deficient.
Yes.
So its point is well taken. Next question. Dr. Sumita, next question, please. Dr. Jayakumar sir, kindly advise regarding newborn vaccination practice in preterm babies.
Sir, regarding the vaccination strategy concerns, it is essentially the same as that for term babies, except for perhaps for hepatitis B. And all newborn babies can be given BCG, OPV, serodose, and hepatitis B once they are hemodynamically stable. And if the mother is HBsAg positive, irrespective of gestational age and irrespective of the birth weight, all babies can be given hepatitis B immunoglobulin as well as hepatitis B vaccine. The initial phase itself, if the baby is stable. Whether the baby is stable or not, we have to. It is better to give that moment. And for others less than 2 kg, we can wait for 1 month and give. So this is the usual protocol that is being followed. All other vaccines, pentavalent, OPV1, IPV, rotavirus vaccine, PCV, all can be given at 1 month intervals as is being given for term babies. So no difference at all. And it is based on the chronological age rather than based on the corrected age. So
that's the point. The vaccination is based upon the chronology rather than the correct. Okay. Thank you so much, Dr. P. Jayakumar, we are running short of time. Dr. Sumedha, next question, please. Sergeant, what are the red flag signs in a newborn baby? And would you advise treating physician or pediatrician to refer the baby immediately to a neonatologist if babies are having red flag signs?
So the answer is, first of all, we have to say, sir, what is not a red flag sign for a newborn baby? So it is better not say that. Only that before addressing the sign, the red flag signs, we have to say that if a preterm baby is, whether such a preterm baby is to be born in a center where there's a level 2 or level 3 neonatal care is there or not, or such a baby can be born in a normal hospital. What I'm saying is that if we know that the classification of preterm is a late preterm, medium preterm, and extreme preterm. What I'm suggesting is if the medium preterm is less than 34 weeks and 28 to 34 weeks, and the extreme preterm is less than 28 weeks. All babies who are extreme or very preterm, means up to 34 weeks, it's ideal to be born in a hospital where there's a level 2 or level 3 neonatal care is there. Then coming to the low birth weight babies, especially the low birth weight, we know that very low birth weight is less than 1.5 kilogram, and extremely low birth weight is less than 1 kilogram. So if the baby is less than 1.5 kilogram, that itself is a red flag sign. Means a preterm baby, very preterm or extreme preterm is a red flag sign. If the birth weight is less than 1.5 kilogram, that's a red flag sign that baby should be cared in a hospital where there's a level 2 or level 3 neonatal care. Then coming to a term baby, of course, the vital parameters, especially the heart rate, BP, and saturation, especially the right upper limb and lower limb saturation should be checked. And if the lower limb, right upper limb saturation is less than 95, or if there's a saturation difference of 3 between right upper limb and lower limb, that is a red flag sign. And any change in heart rate, any change in BP, if the BP difference of 10 more than between right upper limb and lower limb, that's also a red flag sign. Hypothermia is a red flag sign. Lethargy, irritability, seizure, all are red flags. Inadequate sucking, bleeding, except for normal pseudo menstruation. All other bleeding parameters are bleeding tendency are red flag signs. We have to be careful about that. Then altered bowel habit, when the baby is passing the first stool, when the baby is passing the first urine, that is important. And how many times baby is passing stool, how many times baby is passing urine, that is important. And whether the baby has associated abdominal distension or not, if the vomiting is greenish or not, the blood pass baby, if the baby is passing white stool, if the baby is passing blood in stool, all those are red flags. And weight loss more than expected. That's the point I have to stress. That what I'm saying is that we do see many babies with hypernatremic dehydration. If there is a weight loss of more than 10%, there is a chance of hypernatremic dehydration. We have seen babies even having a sodium of level of 176, 190 sodium.
Thank you, Dr. Sarjan. Thank you, Dr.
Thank you so much, sir.
Sarjan.
Time is over, I think, sir.
Is also an important reason. Also, years back, I was taking rounds in the newborn in the ICH. You know, one mother complained, "Oh, my child is not moving the hip, not the joint." Then within, I said, "You go and take a ultrasonogram. Ultrasonogram was not available at that time. X-ray. Within hours, the joint gone. Septic arthritis. Like that, mother was complaining of bystander omissions. I didn't go beyond. Child turned out to be malnutrition and child had a resection. So not moving the limbs and by yellow or green vomiters is always significant, in addition to what he has already told, correctly said. Thank you, Dr. Sarjan. Next slide, please. Do you look for this is an important area. Do you look for red reflexes in all babies? Please explain the method of examination and its relevance.
Yes, we do look for red reflex in all babies. It is a routine screening that must be done. The technique to do it is to use a direct ophthalmoscope in a dark room. Turn it so that you get the bright plain disc. If you don't have refractory error, then use the lens power, bring it to 0 on the ophthalmoscope, sit at around 18 inches or 45 centimeters away from the baby, and look directly into the ophthalmoscope and try to see both the red reflexes simultaneously. You need to compare the color or the intensity of the red reflex in both the eyes and make sure it is equal or equal in intensity. You can also look at them individually, but the looking at them simultaneously is also very important. If you don't see a red reflex, it is an indication to refer to the ophthalmologist immediately. If you see a white reflex, yes, that is also worrisome. If you see opacities that are black opacities in and around the area, but you still see a red light coming through, that could be a cataract. It depends on how much cataract is there. So you can have these black opacities or it could be completely absent. So these are situations where you will refer to the ophthalmologist, because any opacity in the visual media will lead to an absent or an abnormality in the red reflex. Now, it could be a corneal opacity, it could be a lens opacity, a pupil issue, some issue in the aqueous of the vitreous humor or in the retina. So but it is not up to us to figure out exactly what it is. Our job is to figure out if the red reflex is equal in both eyes or not. The slightest of doubt, refer to the ophthalmologist. It is up to them to tell us if it's normal, and if it's not normal, they will do the needful. So for us, do check it in every baby. If there is any abnormality, slightest of doubt.
Possibility is retinoblastoma is also possible.
Yes, sir. One of the reasons for white
Thank you so much. It's very clear. So message is clear. You look for a red reflex with the help of an ophthalmoscope. That's the need of the hour for all newborn babies. That in simple method.
Hello.
Dr. So brief, would you please elaborate?
Yeah, thank you, sir. But
yes.
I think it will be very tough for me to elaborate in brief about the surgical newborn. So I will just concentrate on some of the few points, like which are the main entities and chief diagnostic features and treatment in brief. So some of the most important surgical emergencies which we can see in neonates especially is first will be necrotizing enterocolitis. The others include tracheoesophageal fistula, malrotation volvulus, duodenal atresia, annular pancreas, and various intestinal atresia. And lastly, Hirschsprung's disease. These are some of the most common surgical emergencies in a neonate. So coming to the important clinical features. So when will we suspect that the baby is having a surgical abdomen? So the chief complaint will be the baby will be having abdominal distension, will be tense, tender abdomen with an increase in the abdominal girth. And the second clinical feature will be vomiting. It can be bilious or non-bilious depending on the level of obstruction. Like in a malrotation, it will be bilious vomiting, whereas in a like in the case of a pyloric stenosis, it will be a non-bilious vomiting. And also the third point is the increase in the pre-feed aspirate or pre-feed residuals. So if there is an increase in the aspirate, it can be an altered aspirate. So this is the important indicator that there is something problematic in the abdomen. The other three important points are blood in stools, delayed passage of meconium, especially in aganglionosis like Hirschsprung's disease. And last point is in babies with the tracheoesophageal fistula, there will be increased frothing of saliva. Coming to the treatment in brief, if in any case of a surgical abdomen, the first and foremost thing is we will have to give a period of bowel rest, nil per hourly, and we'll have to start the baby on total parenteral nutrition. We can give either through the peripheral cannula or a PICC line, depending on the unit protocol. And also we'll have to start, especially if it is an NEC, we'll have to give broad spectrum antibiotics. And the fourth point, the definitive treatment like surgery, depending on the type of the illness, whether it is due to NEC stage 3 or due to malrotation, whatever it is, depending on the type of the disease condition, we'll have to decide on the type of surgery.
Linz, I think we have to add diaphragmatic hernia and coronal atresia also.
Hernia and coronal atresia also have to consider as a surgical.
Yes,
but those things nowadays we diagnose natally. Dr. Sajjan, we make a diagnosis natally. Okay, thank you so much. Next question, please. We are running short of time.
Thank you.
Dr. Samita. So it's over. Thank you. That's the last question. So my panelists have done justice to the questions that I have asked. I hope that the listeners are benefited. I would like to say big thanks for the listeners. So they were waiting. Right now there are 33 participants. So that's a great thing in this 9.3 hours, 9.4 hours. I would like to thank once again NNF Kottayam, IAP Kottayam, Dr. Sunu and Dr. Balachandar and all the stalwarts of Kottayam, Dr. Sumaran sir, Dr. PR sir, Dr. Savita madam, and everybody for giving me the opportunity and listening. And also once again my panelists, extreme panelists, Dr. Sajan, Dr. Lins, Dr. Sumita, and Dr. PR Jaykumar. Okay, thanks once again. So I think I can't entertain questions because we are running short of time. It's around 10 o'clock is my sleeping time. Sorry. Okay, Dr. Sumita, a few words.
Thank you, sir. Thank you to all of us who participated.
But sir, may I ask the senior members to share with us a few words?
Okay, sure. Okay, sure.
Almost all are there towards the end, even if it is very late.
Darli madam, Nirmala madam.
Dr. Darli, any comments? Shashidharan sir, they left. Poya.
Madam.
So I want to share.
Madam, unmute.
Yeah.